Thank you. Thank you very much. First of all, thank you, American Diabetic Association, for accepting our invitation for this co-branded webinar, which we are doing with American Diabetic Association. I'm extremely happy and thanking Barbara particularly for giving us this opportunity. I'm also very much thankful to all the audience who will be joining today. And this webinar recording will be there also on our website. We have our moderator, very close friend of mine, Dr. Amit Gupta, who is currently Joint Secretary for Diabetes India. He is also part of International Advisory Board of American Diabetic Association, and he is chair of International Diabetic Federation School of Diabetes. So I'm requesting Dr. Amit Gupta to introduce both the speaker, and then whatever the questions and in chat box will come to you directly from RX, and then you can ask or you can take the comments directly also. With this, I request Amit to introduce both the speaker and then to start the webinar. Thank you.
Thank you, Dr. Bansi. And it is really a pleasure to have this continuous association with the ADA, which we are having for last few years. And we regularly have webinars with the ADA, and this is a ongoing program. So we are really happy and grateful to the ADA for extending the support. And ADA is a very valued organization in India, and people look up to many of the guidelines and many of the standards which are given by the ADA. So a lot of partnership opportunities exist between the ADA and the Indian Diabetes Associations and the organizations Diabetes India. So welcome, Barbara, welcome, Amy. I can see Rich and Aman, and as well as Uzma and Zenia from the entire DSME team from the ADA and the international program team. Let me welcome Barbara. So Barbara is a very senior leader of the ADA, responsible for the international diabetes education programs. And we have the pleasure of having Amy, who is currently the president of medicine, education and science from the ADA. So we have two stalwarts from the ADA presenting this webinar. And this webinar is very, very important because we are going to talk about the evidence-based diabetes self-management education. And I believe this is one of the most important component when it comes to diabetes management if you really want to support your patient. And ADA is one of the organizations which has a very structured approach when it comes to diabetes education. So we would be happy to learn from our colleagues from the ADA. So I will hand it to Barbara first so that we learn about this DSME program. So over to you, Barbara.
Thank you, everybody, for joining us today. It is our complete pleasure to talk to you about the topic very, very dear to Amy and I, diabetes self-management education and support. And we're going to focus on how to create a lasting behavior change through evidence-based diabetes education. And I'm going to be asking Inam to progress the slides. Thank you. My name is Barbara Eichhorst. I am a vice president here in American Diabetes Association. I'm also a diabetes care and education specialist. And with me, I have Amy Hess-Fisher, who is also from Chicagoland. And she's our president of healthcare and education in American Diabetes Association. Next. Our learning objectives are to outline the scope and practice of diabetes self-management education and support, and I would just call it DSMES because otherwise it's mouthful, and review the standards related to DSMES and expected outcomes. And not too many people realize that we actually have standards of care that are evidence-based and are updated on a regular basis to outline the framework of diabetes self-management education and support that is meant to drive expected outcomes. So we're going to talk about that, and we're going to strategize on the behavioral components. What is it really that helps people with diabetes to take the knowledge and then apply it into habits and behaviors that produce behavior care outcomes? As we all know, diabetes is really most of the diabetes outcomes are related to healthy behaviors that people apply on a daily basis that are able to produce a desirable metabolic care outcomes. And then we're going to also apply that infrastructure, the evidence-based infrastructure, and the specific intervention models that can produce those outcomes. And that model is education recognition program that we're going to introduce you to today. And finally, we're going to strategize how Dsmes practice can support the growth and development of a diabetes care and education specialist, such as Emmy and I, who are both functioning within the role of diabetes care and education specialists for a very long time. You probably noticed that I didn't introduce ourselves as a registered dietitian, but I introduce ourselves more as a diabetes care and education specialist because that's a role that we are functioning within. So the benefits of Dsmes are many. Obviously, it improves A1C, glycemic outcomes, improves management of blood pressure and cholesterol, addressing the ABCs of diabetes care. Also, higher rates of medication adherence, people who are a part of that, the structure Dsmes. So keep in mind that Dsmes is defined by that evidence-based structure that drives those outcomes. We also know that there is fewer or less severe diabetes-related complications. We are able to observe a healthier lifestyle behavior, such as better nutrition, increased physical activity, and the use of a primary care and preventive services. And that is really the key. The people who are very engaged in diabetes education, they're also much more engaged in seeing their doctor on a regular basis. And then also get the preventive services and the care that helps to decrease any complications from diabetes. And of course, it enhances self-confidence and management in diabetes, decreases healthcare costs, including fewer hospital admissions and readmissions. Finally, the heart of effective diabetes care is the ability to empower people living with diabetes. So it's all about, when we think about diabetes education, so it is a little bit about education, but it's like a micro, situational problem-solving education. But it's really to establish a very strong connection between a diabetes care and education specialist and a person living with diabetes, where we are partnering with them to bring the best they can be, and then really be a support. And it's a lifelong support with diabetes education, that we are partnering them to adopt healthy lifestyle and then adjust to their diabetes care, because diabetes care changes over time. So that education at the beginning is not going to be the same as education and support that they would need 5 or 10 years into managing diabetes. So we are really creating the guiding principles of Dsmes, where there is a robust and an established framework of work that we provide for people with diabetes within a different infrastructure, within different hospital setups or clinics or outpatient, inpatient, community, and so on. But it is to understand its pivotal role of the shift and how it fits as an infrastructure within the specific environment and the patient care needs. And finally, we empower individuals living with diabetes, and we optimize care outcomes across diverse settings.
Let me introduce you to the foundation of the standards. And just to kind of back up a little bit, that the first national standards were published in 1984. And ADA has been involved in the education recognition program kind of evolution since 1986. So we're talking 40 years of doing what we're doing. And we have come so far from those first standards. So I want to just go over the 6 standards that are currently in the 2022 National Standards paper. The 2027 National Standards are being updated this year. So stay tuned for what wonderful things to come. But when we think of the national standards, like I said, they're the foundation of quality, continuity, and ongoing care. So when we think of standard one, they all fit together. So 1, 2, 3, 4, 5, 6, they're all going to fit together, but they all build on each other. So when we think of standard one, is that support for DSMES service. We do not live in a bubble. We need to be asking external stakeholders for input, identifying how we do things better. And that is the foundation of standard one. Standard two, population and service assessment. Now, while most services, before they even start their ERPs, they're taking this deep look into who are the people that we want to serve, who are the people that we should be serving. And that's really the whole point of standard two. I find it to be so entirely valuable that on an annual basis, as education recognition programs, we are assessing each of these standards, because every year, like Barbara said, when it comes to DSMES for individuals with diabetes, we need to be assessing ourselves, and we need to be assessing, has something changed? Are there gaps that we need to address? What do we need to do to make our services better? Standard three, of course, is the DSMES team. So all of the individuals who are part of that education recognition program is really how they fit in, what they're going to be doing. And that includes, now, when we look at DSMES teams, of course, as a dietitian, Barbara and I said, again, we either a dietitian or a nurse or somebody that's a certified diabetes care and education specialist, or somebody that has board certification in advanced diabetes management. But that includes all the other disciplines, as well as diabetes care and community coordinators. So again, when we think of individuals like community health workers that we have in the United States, MAs, medical assistants. So we want to make sure that we are looking at community-based services as well. And I think that certainly when we think of all other countries, India included, again, who else on your care team that can be included? They don't necessarily have to be a nurse or a dietitian. We have to start expanding that knowledge of who can help us meet the needs of the person, knows and speaks that language, can get into their homes. Again, all of those things I think are really important. And that's something that my dream this year is looking at better ways to use kind of community-based lay individuals as well. Next slide, please. Standards 4 through 6 are really, again, like I said, there are all 6 of them fit very nicely together. But when we think of what we identify as DSMES, these 3 all really work in tandem to highlight the quality and the value of what we do. So when we think of standard 4, the delivery and design, that's the curriculum, that is what are we teaching, that's that foundation. Again, we need to have a foundation of content that everyone is speaking the same language. We know that this is about person-centered care. This is about the person that's sitting in front of us. What do they need? Not what do we need? What do they need? But we need that foundation so they're not getting mixed messages. Standard 5 is the meat of what we do as diabetes care and education specialists, working with that person or persons with diabetes to deliver all and assess and identify what they need and really have a conversation. I know Barbara said that earlier, that, again, DSMES, we need to erase the thought that this is a one and done. We have to think of this as an ongoing continuum. And I am so very fortunate at the job that I work, that I have been working with some of my patients for over 20 years, that they've followed me at various places, highlighting the fact that DSMES is valuable, but it is a continuum. That my surly teenager that I met when I first started, again, is now a young adult, and her needs are very different than they were before, but the needs are still there. Finally, standard 6 is one of my favorite standards because it highlights the value of what we do. Outcomes are what every organization needs. And so when we think of measuring and demonstrating those outcomes, identifying, aggregating what the person with diabetes, how have they done in relation to our DSMES, but also CQI project. Again, I think that there's nothing better for any DSMES service to be involved in CQI projects to really show that value and highlight. I really don't think that, and this is my personal opinion, that even in the US, many services, they don't always see the value. And I want to find some way to make it really clear that when we think of DSMES, unfortunately, as in the last 40 years, this is a business now, and we have to show that we are cost neutral. Next slide, please. Now, the standards of care for 2026, I am certain all of you have really taken a deep look at it. Again, this is sitting on my right next to me in my office. So it is near and dear to my heart. But for DSMES, chapters 4 and 5 are the key chapters that include DSMES as well as the assessment. So, again, they can fit in everyone's, in all of your clinics. But again, when we think of DSMES specifically and the national standards, standards 4 and 5 are crucial to what we do. Next slide, please. Now, if we just take a little deeper look at standard 4, as what Barbara has said before, as this is that ongoing theme of person-centered collaborative care. Standard 4.1, we have to have that communication style that's culturally sensitive, that's strength-based. Again, we want active listening. And I think that, that's the value of DSMES, that when we think of the time that we can spend with individuals with diabetes, we're creating that relationship to really identify their individual needs and their beliefs, identifying their literacy. And so when we think of that 4.1, that has always been part of the assessment of DSMES. We need to know who we're talking to, what they want to hear about, and what they believe, so we can help them and really identify the goals and improve their outcomes overall. And certainly 4.2, is when we think of, it's a team-based approach. As you saw, DSMES team. Again, no one is just working with that person with diabetes. It's everyone that person is involved with. And I think that we need to always identify that this comes down to the person is the center of everything that we do. We are all merely consultants, in all of this. Next slide, please. So when we think of that person-centered decision cycle, so again, I know that many people have already seen this. This is kind of part of everything that we do, but I want to just kind of highlight that, these are, when we think of the goals of care, that we have so many things, as clinicians, again, even in clinic yesterday, it's like, all right, have we looked at, I'm looking at all the standards of care, eye exam, foot exam, again, dental, again, have we done their labs, what are their medications, again, all of these things that are going on. So we're going a million miles a minute, but it still comes back to, are we preventing those complications? Are we optimizing quality of life? Again, and we have to really assess and then consider those factors, use shared decision-making to come up with the goals that are right for the person that's sitting in front of us, agree on that plan, and then implement, as well as that ongoing support. Next slide. When we think of the guidelines themselves, every single chapter that you read in the standards of care are about person-centered. And it's for type 2 as well as type 1 management. We know that it has to be tailored for the person that's in front of us. Shared decision-making is tough. I've been, working as a diabetes care and education specialist for 26 years. And, especially that I have 30 minutes to see a patient in conjunction with the endocrinologist that I work with. So we don't have a lot of time. So it's sometimes easier to be like, do this. It's like, no, I have to take a step back because we have to identify that shared decision-making is the only way that we know that that person is going to implement it. And then we're going to see those outcomes. And we certainly have to assess so many other things, cost and, the access, and which is one of the bigger pieces, especially with technology that we're seeing available today. And while we know, again, when I think of India, the many differences across your entire country, again, we can think of the cultural differences from the north to the south, and that's the same, in the United States, that we're seeing so many differences, and that we really have to tailor our needs to the person that's in front of us. Next slide, please. Now, standard 5, 5.1, 4, 5, 6, and 7 highlight all of the national standards that I was really kind of highlighting to you. That 5.1 is about assessing. 5.4, it really comes down to how we're conversing with that person, again, motivational interviewing, behavioral strategies, all of those things that culturally, appropriate, socially appropriate. We know that I'm coming to you live from my basement, again, and I see patients from my basement via telehealth. It has been a game changer for so many of our patients. So finding ways, especially in areas, do they have the capabilities? We want to make sure that everyone has these capabilities and allowances. And certainly we know that, again, I don't want to keep belaboring this issue, but I cannot say enough about when we think of CQI and improving outcomes and cost. We know Dsmes is one of the cheapest ways to be able to do that. Next slide, please. Now, again, I just want to highlight that when we think of self-care itself, again, it all comes down to the person that's doing it. They live with this 24/7. And so when we think of why self-care behaviors are not met, it has a lot to do with, again, are they not telling us something, or are we not asking the right questions? But it's important to note that 20 to 30% of prescriptions in the US are not filled. 50% of medications are not taken as prescribed. 86% will check their A1Cs annually, which is great, but we want to see that 100%. 65% only monitor glucose levels daily. 28% visit a diabetes specialist annually. 14% participate in diabetes healthy eating plan, and 11% only perform recreational activities. Again, Dsmes, we can do better. We know that Dsmes can improve those numbers. Next slide, please. Now, finally, when we think of the core content of Dsmes, to the right, you see the 9 content areas of what needs to be included within the curriculum, as well as what are we assessing. On the left-hand side, the 4 critical times for Dsmes. This was introduced in 2015, and it highlights all of the times that people should be receiving Dsmes. Again, this is ongoing. So at diagnosis, annually, or when treatment goals are not met, when complications arise, and during life and care transitions. So again, we want to make sure that we are meeting those needs. Next slide, please. Now on to Barbara.
Thank you, Amy. Amy just reviewed the evidence behind effectiveness of diabetes self-management education and support, and then what it takes to deliver it. What I'm going to focus on is showcase the actual infrastructure that drives those expected outcomes. And the infrastructure, it's called Education Recognition Program. And the way that this is done, it is a way to provide that quality, the 6 standards of Dsmes within a specific infrastructure that Amy discussed when she said there's a 6 section of those Dsmes. So American Diabetes Association is a provider of those programs. And here in US, it's a way to get reimbursed for diabetes education. So the only way to get reimbursed for the diabetes education, DSMES, is to be a provider. There is 2 providers here in US, but that would indicate that we the programs that we accredit or we create the education recognition program, it means that it meets those 6 standards. And then now we officially have our first international site, which is in Saudi Arabia, and we're very proud of it. In US, we have over 3,700 sites providing DSMES. And these are the outcomes, section 6, Emmy's favorite. So every year, all of the ERPs, and I have been one of the ERPs for many years, just like Emmy, have a privilege to share our outcomes with the national ERP. So these are the 2025 national benchmarks coming from those education recognition programs. So over 75% percentage of participants with decrease in A1C, 78% of participants with decrease in ER visits, which it's a big deal because some of those ER visits can be preventable, and 78% decrease in participants with the ER visits. That's a huge number. 66% of participants with decrease in weight, which is also very important. Overweight, obesity being a separate medical condition, but is also complications of diabetes. Seeing the decrease in weight also is really a good thing. And 1.3% annual decrease in participants' A1Cs, 75%, a little bit over 75% percentage of participants with decrease in hospital admissions, and 2.2 kilo actual decrease in participants' weights. And this is just because we're very proud of our first international ERP. We have celebrated with the press release, and then we're just proud that the standards are being applied outside US. The standards are very they're very broad and adaptable to a different culture, different countries. This is what makes it very special. We don't dictate exactly how things need to be done. We give a flexibility for adoption of a cultural and an overall intervention. So that's what's nice about those 6 standards of DSMES, as you can really apply them within a different cultural setting. They're meant to be easy to apply. We just provided infrastructure that is necessary to drive those outcomes, like appropriately trained clinicians, appropriate curriculum, and other things that would that are built in a way that is going to get us what you want to get with your outcomes. We don't even dictate the outcomes. We allow people to really identify what's meaningful to you with the outcomes, and then just keep on improving. So every year you measure something that is driving the practice and your populations to a better state of diabetes. So I'm going to show you an example of one of the standards is to have a patient-centered curriculum. So ADA has a lot of patient education materials, but that's not necessarily a curriculum. When we talk about curriculum, I'm going to give you an example of curriculum, but what we do have, and we have just recently started to publish is the standards of care for people with diabetes. We don't call it exactly standards of care. We call it your rights and care standards, a guide for people with type 2 diabetes. What this is taking the standards that all of you clinicians have and are familiar with, but really translating it to letting the person living with diabetes know what to expect. Because really with diabetes, self-management, that's what it means, self-management. A person living with diabetes has to be his or her own advocate, because that's their diabetes, they're the CEO of their diabetes, and they're partnering with us, with diabetes care and education specialists and all of the clinicians, in helping them to get to the goals that they want to reach. And that's what true engagement is. And then true alignment, and will allow people to do those things. A lot of times, we have as a dietitian, I gotta tell you, it's my early years. I was so good with telling people what to do and how to do it, and the patients were coming back and they were not doing anything. They will keep on telling me that I have done such a good job, I'm such a good teacher, but they're not able to apply anything to their life. So it took me years to realize that it's not about me and what I teach, is about a person living with diabetes and what they're willing to learn with my partnership and my assistance. So this is a very big deal, to allow people to have their own guide that would guide their care, and they would know what the expectations are, and it's literally aligned with what you have in the healthcare professional standards of care. And this is an example of the people with diabetes curriculum. So this is the one from Saudi Arabia, where we have kind of created, there's a lot of content that needs to be covered. There's like 9 different topics or domains that we have to address: the pathophysiology, healthy eating, monitoring, acute risk, chronic risk, coping, a lot of stuff that needs to be done. But we do need to translate it into a very simple, what can you do today to improve your diabetes? And what can you do today till the next time I see you, so we can celebrate your success? So we don't throw everything on a person living with diabetes, especially with Dsmes being provided in a group setup, because we know that the groups are as effective as a one-on-one, and in some cases even more effective. So we have to individualize the care, but for, let's say 5 to 10 people at the same time. Sometimes we do it one-on-one, sometimes we do it in a group. And this is an example. I put it out for a reason, because when Emmy was talking about those 6 standards of care, and then when we wanted to relate to the skill sets of a diabetes care and education specialist, the way that we develop our skill sets as a diabetes care education specialist, yes, we can take a course or 2 or 5 or 20, but really the way to grow the skill sets is to see and work with people with diabetes on an ongoing basis. We measure the success in my clinics. We have always measured the success if the patients are coming back. If the people if they come for the session and only one comes back, then I gotta think, what will I do differently next time to make sure that I, as a diabetes care education specialist, engage that person in a way that that person sees the way to come back? Because diabetes education cannot just happen at one time. We don't have a magical one and here you're going to change. It's almost like a micro learning that people learn, like with medication. It only works when you take it. Education only works when you attend it and you are engaged. And people oftentimes, they don't have to make a lot of changes, but the fact that they're coming back for the sessions or coming back to see you, that's a very engaged individual, because they are trying on their own terms.
I don't want to belabor what you see on the screen here, but I just want to highlight the fact that as diabetes care and education specialists, we should and are held to practice competencies. And so what you see in front of you are those practice competencies, these domains that in theory, all diabetes care and education specialists should be assessing on an ongoing basis as we do annual status reviews for our education recognition programs. Again, DCES should be doing this as well. So we are providing that quality care. And we are at the top of our scope when it comes to clinical management, as well as advocacy and communication, that person-centered care. So I just wanted to kind of highlight that there's a very lengthy document on the practice competencies in these domains that diabetes care and education specialists are held to. Next slide, please. And with that, again, my call to action for all of you is that, again, we know that what we do matters. What we do does improve outcomes. So using validated and reliable approaches to provide individuals with diabetes that education and support, effectively prepare diabetes care and education specialists to do the work, to provide that quality as well as drive those desired outcomes. And again, I can't say enough, outcomes. Again, we have to measure them to show our value and to show what diabetes self-management education and support can do for all people with diabetes. And with that, I thank you for listening to us, but I'd love to hear some questions. I know Barbara would love to hear some questions as well. So thank you for your time today.
Thank you, Barbara, and thank you, Amy, for the wonderful presentation. And let me tell you that I believe the solution for this mounting epidemic of diabetes, obesity lies in the education, and not it doesn't lie with the medication. The medication, they have their own role and importance, but the structured education is something which is required, and really it is an unmet need of the world. And it is not just one country, it is the situation all across the globe. And I'm really happy to see the impact which you are making. And I can say that this is a real example of implementation science. So whatever data you synthesize in the research and everything, it is the implementation at the end of the day that matters. And this is one of the most robust program, I can say, globally when it comes to the education recognition program. And I'm really impressed with the numbers which you have shown and the kind of engagement the people they show with the program. So by the time we get some of the questions in the chat box, I will encourage the participants to send us the questions write the questions in the chat box. But I do have some questions on my side. That you have been running this program for years, and now it is one of the most globally recognized and structured program in the diabetes education. So one question is that I think this is delivered mostly in person and in group setting and in 1:1 setting. So do you think such a program can be delivered in online setting as well? And can it be, because there's challenges in countries like India where we don't have recognized diabetes educators, and we don't have anything that pipeline that actually motivates or that brings people into so that people can make it really their earning in the life source of income as well when it comes to educators. So most of the time they are part of some teams, some good teams when in some hospitals, but not in every diabetes clinic. So your thoughts on that?
I can address it. So yes, our education recognition programs of American Diabetes Association also include virtual programs. So we have multiple virtual programs, both type 1 diabetes and type 2 diabetes and gestational, that are recognized by American Diabetes Association to provide virtual Dsmes.
Very nice. And just yeah, please.
If I could add, if you don't mind, again, at the University of Chicago, again, we have both in-person and telehealth, again, and half of my time is one-on-one telehealth. We also have 2 online telehealth group classes per month. So we know, and we have plenty of data that shows that telehealth online all produce very similar outcomes. Again, provided that we're doing individualized goal setting for individuals.
So, I mean, this is really nice. And so you must have compared the outcome in both the programs. And
we did.
So do you see any difference in the online delivery and in-person setting delivery when it comes to the outcomes?
Well, I think one-on-one and group are 2 different things. I think that, you have to identify the individuals who are going to be best suited for online, and do they have the infrastructure to be able to do it? Again, we know that that's one of the bigger issues. But when I look at one-on-one, the outcomes of what I'm seeing for the patients that I'm seeing are no different than when we do in person versus telehealth. Group, it depends on the number of individuals who are in that telehealth visit, and are their voices being heard. The more individuals that are in a class, the less likely that we might be able to more personalize and individualize their needs. So again, this is just Amy's opinion, not necessarily anything that has been written. But when we see 5 to 6 individuals in an online class, it's more manageable. And there has to be quite a few requirements. Like, you need to have your video camera on. You need to be engaging, or the educator needs to be asking questions for each of the people that they're engaging, all of them. So there is a little more work that the diabetes care and education specialist needs to do, but I think it's valuable at the end of the day. So I think it really comes down to that ongoing training for diabetes educators to be able to know how to do this effectively.
So this is really nice to know. And I just want to understand one more thing, that I see a large number of people with diabetes, they are engaging very effectively in these programs. And whether in person or whatever, irrespective of the type of the program. So in your experience, what actually motivates them? What is the motivation behind them to keep constantly engaged with such a program?
Go ahead, Amy.
All right. I think that
What's your secret sauce?
No, we have to acknowledge that it's not about us. I think that, I audit diabetes programs as well. And so again, having conversations with programs saying, why don't they come back? Again, and I think are we listening to what they want? And that's really the only thing that is of any value. That if that person is heard, whether they're a child or an adult, whether they're heard, they're going to come back. And it's about honesty. It's about that relationship, that they're not going to be penalized if they didn't do something perfect. So, I really do feel that, I can speak from, over 20 plus years of seeing many patients, that they come back to me because we've created that relationship, and I'm not going to judge them, and I am going to listen to them. I prefer to speak less than they do, that I'm hearing what they have to say.
And I want to add to it, and I think that another thing that is relevant, and I'm sure Amy is going to agree, is closing the loop with the referring provider. So it's the diabetes care and education specialist needs to be really partnering with that physician. And that has to be really a strong partnership, that we're talking the same language. So when you, Dr. Gupta, I see your patient, then the patient sees you as like, hi, Amy, how did Barbara do? What did you guys talk about? So then this way, you as a physician, Dr. Gupta, you're closing the loop, because the patient sees that we're on the same team, that we're not fragmented, and we're talking the same language.
Oh, Barbara, you hit the nail on the head. I think that it's so important that, again, the most individuals with diabetes, again, the physician, the provider, is the one that, they're going to listen to the most. So if that provider says diabetes self-management education and support is valuable, and that there is that communication. I think that why I am so successful with what I do is that I work hand in hand with all of the endocrinologists that I work with. Again, we have a really good relationship. We speak to each other. I give them updates. So it's always like, well, just ask Amy, again, and I like that, because again, it means that that provider values what I have to say. That person with diabetes is then going to feel the same.
I think this brings a very important point for discussion, that the care has to be continuous. There has to be a good rapport between the person who is referring and the educator, and at the same time they should be talking to each other as well, that what is happening. So the patient remains confident. The person living with diabetes is confident all the time. And let me just share our experiences in India. Recently, there was a lot of companies, you can say, that they started to provide doctors this service, that we provide education online, but none of them actually works because it is fragmented. So there is a total disconnect between the provider as well as the educator. So Amy and Barbara, you guys are really experienced ones, and let me congratulate you. Today is the International Day for the Women in Medicine and Science, and I'm really happy to have this conversation with one of the two top women leaders in this science and science space. So many congratulations to you and all the Genia and the Ayman and who have joined this event. One question to you. For example, I want to learn education as a healthcare professional. So what are the resources I should look for? How ADA can help me? And how I can learn from ADA that how to deliver the diabetes education.
I wanted to thank you for being a physician, and I know you for a very long time, and you have really and the physicians that you work with in India has really fostered that relationship with the diabetes care education specialists, and you are trying to create the ecosystem that really provides that collaboration. So I wanted to thank you on our behalf. What my recommendation would be is to literally print out those standards of care for people with diabetes, their rights. And as a physician, you can give it to them and tell them, these are the things that will help you to manage your diabetes. I'm here, Dr. Gupta, I'm here to support you with this. Let's work together, and then don't forget that you also are a diabetes care education specialist. Diabetes care education specialist is somebody, it's not a certification, it's just you have enough of expertise and continuing education hours that you provide Dsmes. So it's nothing stopping you from being, in fact, we have several physicians who are certified diabetes care education specialists because we partner with it. So my recommendation is print those standards of care for people with diabetes, give it to them and work with them.
Yeah,
go ahead, Amy.
This is very nice. And Barbara, I would be happy to formally have this CDCS qualification with me. So please do help me with that and help me enroll in one of the courses which you are running. And I think this is very important because even as a team, if the team leader knows that how to deliver the education, then probably you are able to educate your team better and manage your team better as well. So you have seen the India, many people from the India and your experience. So I want to see this happening in India and the other part of the world as well. So how do you see that, how it should be modified, how it can be delivered in India, what will work in India? Maybe I think we need more discussion on that because the education recognition program, the Saudi is a real experience, and I'm sure you are going to get a lot of insights once you complete a couple of years of education there, then probably you will be in a better position to talk about that. But that is really a very big achievement as well as a very big insight. So how do you integrate with the policy, and what is the best way to approach?
The best approach is to contact us. We have the team, the whole team that is involved. We have Inam, Uzma, Amy, myself. We're all part of it's called Education Recognition Program. We work with you on an individual basis. We provide a lot of individualized assistance to make it work. So feel free to contact us, and we can get you going.
So I think all the participants who are listening, one of the key takeaway from today's webinar is that education really works. The only thing is that you need to structure it. Sometimes the education which we provide in a fragmented and the unstructured way, it may help a little, but it doesn't lead to the outcomes which we are expecting. And as Barbara and Amy have shown, that a structured education program can reduce the HbA1c to the tune of 1.3 and even more sometimes. So this is as good as any other anti-diabetic drug which we are using in our clinical setting or the clinical patient. So why don't we invest in the education of our patients? So I will encourage all the listeners today that it is your opportunity. ADA is opening its arms. They are welcoming you. You can write to them. You can contact them. You can have your education program. It is not necessary that it is through an institution or it is through a if you are running a hospital, if you are running a big clinic, or if you are interested in educating others, then probably you can write to the ADA and get all the know-how that how to integrate these programs. And obviously from the society level, we will be engaging regularly and trying to do whatever we can do. But I think this needs more and more more and more initiative from the physician side as well. And I request all the physicians that don't consider that it is the duty of the diabetes educator, as Barbara rightly pointed, that I think all of us are educator first, and then we are the clinician, because we should recognize that, and we should take it with a pride, with a sense of pride. And so this is my takeaway from this webinar. And I'm definitely going to chase Barbara and Emmy for a certification. And why don't you enroll me in one of the patient program first? Because I want to see that how exactly you deliver this.
We can do that.
Right. Thank you. So I think we still have few minutes. If there is anything you would like to bring out, then I would be happy to listen to you.
I think Inam just posted the website how to contact us for the education recognition program. So she put it in the chat. Thank you, Iman.
And one other thing, Iman, if you wanted to add, diabetes.org/ERP, because you were asking kind of resources, that website gives you kind of foundational standards. So it shows you, because I think that certainly I've spoken with in Egypt before regarding the national standards, and they are a foundation. They're a foundation regardless of where you are in the world. Curriculum is going to be based on where we are in the world. We know that that's going to be one of the major differences, but all the other standards, that foundation can be utilized wherever you are, even pre-ERP, just so then you can get a better sense of who are our external stakeholders? What are our gaps? What do we need to do? And the American Diabetes Association has done such a wonderful job with templates showing all of the things that go into the standards themselves, and those are available to anyone.
I think I request everyone to visit the website today and try to explore the resources which are already available. At least you can start by using these resources wherever you feel, and that these resources are, you can distribute these resources to your patients and everyone who requires education. So this can be a good starting point. And once you start developing some kind of interest, then you can always reach out for more official engagement, as well as more official learning, and guide your patient for these courses as well. So one question, do you provide courses to the overseas patients also?
We have what's called Institute of Learning at American Diabetes Association. And that's actually all the courses for the healthcare professionals with continuing educations are free. And there are about diabetes education, about anything, pretty much kidney disease, anything you need, a lot of different courses, all free, all manageable. You can take it anytime you need it, and you can get a continuing education.
Thank you, Barbara. Thank you, Emmy, for highlighting this. On behalf of Diabetes India, I would again like to thank you for taking out time for this important webinar on the evening of the, you can say, because the Diabetes India Congress is starting tomorrow, and it is a good starter. So this is the opening session, you can say, and this is going to be good learning for each one of us. And we shall stay connected and stay in touch, and try to do more for the people with diabetes all across the world, with the support we are getting from the ADA and all the ADA leaders. So this is amazing, and I'm really grateful and thankful to you. So thank you. Thank you, Barbara. Thank you, Barbara. Thank you, Ami. Bye-bye.
Enjoy the conference. Bye now.
Yes.
Bye-bye.
Thank you. Thank you so much. Thank you. Bye-bye.
Bye.